Good evening, friends, and welcome back to the Thursday evening teaching session being brought to you from LTMMC and General Hospital, Sion. As we announced on the various groups, we have once again started these classes physically at Sion Hospital. We had taken a break on online classes during the monsoon period. So we once again express our gratitude to the authorities at Sion Hospital, especially Dr. Radha Gildial Madam, Head of the Department of Sion, and the Dean of Sion Hospital for allowing us to conduct these classes here. And we thank Aristo Pharmaceuticals who have supported this webcast with an educational grant without any conditions, and we thank them for the same. So today, as this class will be hybrid from now on, as in there is a physical class at Sion Hospital. So those of you who are in Mumbai are requested to try and come to Sion so that there is better interaction and learning. And those of you who are outside Mumbai can continue to watch this on the live relay. The live relay is on two main sites. One is www.clinicalpediatrics.co.in and the other is DIAP website. So PGs from anywhere can always log in and can even put their questions, and we will try and look at them and answer them. So with that preamble, please spread this word to all your friends and colleagues, students everywhere. And now we start with the case today. Today's case is being presented by Dr. Devina Datta.
Good evening. My name is Devina Datta and I'll be presenting today's case. So my case today, her name is Prachi. She's a 2-month-old female, first by birth order, born of non-consanguineous marriage, resident of Ghatkopar and hailing from Uttar Pradesh, and the informant being my mother. She's been brought with the complaints of increased work of breathing noticed since since 2 weeks of life. The mother complains that increased work of breathing has been present since 2 weeks of life in the form of increased rate of respiration, which has been gradually progressive. It is aggravated with feeding and crying and is relieved at rest. However, no treatment for the same has been taken till 2 days back when she was referred during routine immunization to a higher center in view of increased respiratory activity and poor weight gain. She also complains of poor weight gain and feeding difficulties since 2 weeks of life. Complaint of suck cycle is present. Complaint of forehead sweating is present. No history of bluish discoloration of lips and tongue. No history of cough, cold, fever and noisy breathing. No history of lethargy and decreased oral intake. No history of decreased urine output, abdominal distension, periorbital swelling, and no history of edema. Antenatal history: spontaneous conception, registered at 3 months of gestation. Iron and folic acid tablets were taken. 3 to 4 ANC scans were done. They were told to be normal. No history of maternal drug intake or irradiation. History of fever at 5 months of gestation for 6 days, associated with complaints of mild chest pain. This is not associated with any rash and it resolved with symptomatic medications only. No other treatment or no other tests were done. No history of gestational diabetes mellitus or preeclampsia. Natal history: full-term normal vaginal delivery. Baby cried immediately after birth with a birth weight of 1.75 kgs. History of NICU stay for 2 days in view of low birth weight, and she was discharged on day of life 3. Birth vaccines taken and exclusive breastfeeding was started. There was no history of difficulty in feeding during that period. Dietary history: she's on exclusive breastfeeding and the mother has been noticing history of complaints of suck cycle since 2 weeks of life. She feeds 3 to 4 times during the day and 1 to 2 times during the night. She's been immunized with birth vaccines only. Developmental history: gross motor partial neck holding is present. Fine motor hands closed. Language cooing is present and social smile is present. Family history: mother is a known case of neurofibromatosis type 1 with 3 plexiform neurofibromas and multiple Caffioli spots. There is positive family history for neurofibromatosis over 3 generations in the family. There is no history of heart disease or any history of sudden cardiac death in the family. No history of COX or COX contact. According to modified Kuppuswamy classification, she falls under class 5 lower socioeconomic class. Summary.
Second slide. So, this is a 2-week-old baby who's come with increased work of breathing. No. At this stage, it is 2 weeks, no? So when you saw the baby, suppose on the first day, it was a 2-week-old baby with fast breathing, right?
She came to us at 2 months of life, and the mother said that there was increased work of breathing since 2 weeks of life, but she had not shown it to anyone.
That's what. So I am asking you, if you were there at 2 weeks and this baby came from yesterday, increased work of breathing. So obviously increased work of breathing is not the word which a mother will use. So what will the mother say? What did the mother say?
Hurried breathing or fast breathing.
I have, doctor. I have.
Fast breathing, I think.
So say that. No?
Yeah.
So now what would you make out of that? On that day, on 2 days or 2 weeks, you have a 2-week-old baby with 1 day of fast breathing. So what will you, how will you approach that on that day? See, today now if I put suck, rest, suck and all, it becomes very easy and becomes very narrow. But let's broaden our learning. So on that day, what would you think of?
So we would want to see if there is any associated other complaint as well, like fever. So we would want to see if there's any respiratory tract, lower respiratory tract infection, considering the acute onset of the fast breathing. And also how the child is doing overall. With the fast breathing, is the child feeding well or no? So we would want to see that.
So you are trying to decide the anatomy of the problem on that day. So anything more? You said fever and whether the child is feeding well. What else do you want to know on that day? What are the thoughts in your mind when a baby is breathing fast? What could the anatomy be besides respiratory?
Child may be acidotic.
Very good. It could be an acidotic baby. So now acidosis again can be branched further. So what could be the maybe 1-2 groups of acidosis at that age, 2 weeks? Very good. So one is acidosis out of an acute illness and one is say some inborn error of metabolism, RTA, whatever. So good. What else? Anatomy. One is respiratory, one is metabolic. What else? Cardiac. Okay. Anything else?
In what order? In that order, which order?
It won't be heard outside, sir, unless you speak in the mic. So everyone should speak in the mic only.
In what order?
So sir is asking, a 2-week-old baby with fast breathing, out of these 3, which one will you rank first, second, third?
Respiratory, cardiac and...
Respiratory is first?
Cardiac and then septic.
Okay, so we have a different thought process. So tell us why respiratory first. So which conditions or which anatomies will a 2-week-old baby come with breathlessness to you as the presenting complaint for a respiratory problem?
And which we assume that it wasn't there for first 2 weeks.
So what we were actually trying to get is you should get to the onset, duration, progress. So in fact your first question should have been, was this baby absolutely all right till a day back? because that will make a lot of difference to, so you want to know what happened in those 2 weeks right from birth also, right? But anyway, so tell us which respiratory conditions you think can come with breathlessness as the chief complaint at 2 weeks. લેને હું ત્યાં ઓનલાઈન બી જોઉં છું.
Which other conditions can give rise to respiratory problem at 2 weeks of life? And if it's so hard to think, then you must think that probably respiratory is not the commonest thing, right? Can it be a pneumonia?
Maybe.
Yes.
Yes, sir, maybe.
So why did we not say pneumonia straight away? What is the other thing which usually happens before breathlessness in pneumonia? Fever, right? Correct.
Just a little diversion. I will first ask the mother, what do you mean by fast chalta hai? When she is breathing, I mean, is the breathing fast throughout or only when she is feeding, then the breathing is fast and the breathing is quiet later on? There is no feeding difficulty because remember this is a small baby of 1.7. So she is likely to get tired a little earlier, or they can even have a little baseline tachypnea otherwise also 1 point. So is the baby otherwise also breathing fast when nothing is there, she's sleeping quietly or no? That's the first thing I was, to make sure that what we want to call it as exertional dyspnea. Here what is contemplated as exertional dyspnea. So I will make sure that that is there or no. And also, why do you say that this baby is breathless? How does the mother understand that the baby is breathless? Increased work of breathing or fast breathing. Many mothers will understand that, provided the breathing is really fast. Mild tachypnea, no, there is a significant tachypnea. And it has been there earlier or no? It has been there earlier. So what are the thoughts? Anything which comes at 2 months is likely to be present from birth. You think of congenital as one. So in congenital, what will be there? If not acquired, what will be there? Dr. Tushar said pneumonia is unlikely. It is not a baby who had RDS or something, and that's all. So it's now. So congenital hai to kya? Acquired hai to what is that?
Sir, in congenital, we can say some of the structural lung defects.
Closer.
Structural lung defects, we can say, sir, parenchymal and conductive airways, like tracheomalacia, bronchomalacia, laryngomalacia, and pulmonary hypoplasia, we can say.
He's saying all the structural abnormality is possible. But as Kharesar said, the structural abnormalities usually will have breathlessness starting from birth itself. Okay?
Yes,
And then it, not like for 2 weeks a pulmonary hypoplasia will not be breathless and then will become breathless. It's a different story that they pick up an infection, if they pick up an atelectasis, then they can become breathless. But again, then you will have some other history related to that.
And also laryngeal malacia will have stridor. That can, will it, congenital laryngeal stridor will be present from day 1 or will come at day 15? The laryngomalacia one.
Day 1.
Pardon me?
Day 1, I think.
It's almost never on day 1. The laryngomalacia always starts later on. If it is there from day 1, you think of a structural abnormality. For reasons which I don't know, but laryngomalacia, not from day 1. And it is dash 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 associated with or not associated with noisy breathing, not associated with feeding difficulty. Is not laryngo. If it is associated with feeding difficulty, then it may not be laryngomalacia. It may be structural problem.
Since we are on laryngomalacia, what is the other very striking clinical feature of laryngomalacia?
On prone.
Prone position, the stridor disappears or reduces markedly. Very good. Any normal fast breathing at a 2-week-old baby? Come. Into inverted commas, normal fast breathing.
Breathing fast, becoming normal.
Relaxable chair.
Breathing fast, becoming normal.
Either it could be post-feeding or it could be like a periodic sort
Very
of breathing,
good. So
which is common in
periodic
the
breathing is
paramedic.
fairly common in very small babies, and you need to ask that history. There could be normalcy in between, right? Yeah.
So we already addressed, sorry, sir. We already addressed CNS, meaning acidotic breathing, cardiac and respiratory. Can it be something else? What other things are required for somebody to breathe normally? Muscular, right?
muscle
So
weakness and all.
So which neuromuscular conditions can come with fast breathing at that age?
Any congenital myopathy or
Or
Even SMA.
yeah. So severe SMA, yeah.
So again, a minute difference here is myopathy will be there from birth and is not considered a progressive thing. Whereas SMA is a progressive condition. So the child may or may not be tachypnic at birth, but may become tachypnic later on. 2 weeks is a bit too early, but again, just putting a thought across to you.
Also remember, the mother has noticed tachypnea. So it's not a mild tachypnea, maybe it's tachypnea with a little bit of distress. Also, babies with, what did we say just now? SMA will come for tachypnea, the mother will complain or she'll complain of something else. The baby doesn't have sustained power. So they will have feeding difficulty more than tachypnea noticeable by mother for SMA is less likely. She may complain of lethargy or something if she's an experienced mother. Otherwise, she'll come for difficulty in breathing. And also laryngomalacia, as he very rightly said, changes with position. Anything which is flexed, your airways are kinked. And when you extend it, the sound becomes much less. So laryngomalacia changes with position. Other things may not. But feeding difficulty is very important.
I think the most important part is when the first symptom appeared after birth. If it appeared immediately, it's never cardiac. It's always respiratory. Okay, that is sure. If it's metabolic, it won't come right at birth. You have to have a feed going in and then the response. And the response is vomiting, seizure, and then maybe tachypnea. So tachypnea is not a first symptom of an IM right at birth or early at birth.
And not noticeable by mother that she will complain of, yeah.
So if the doctor has seen tachypnea at birth, it is respiratory till proved otherwise. That's number one. But when you see it a little later, a week, 2 or whatever, the first difference is it a comfortable tachypnic child or an uncomfortable tachypnic child? Okay. If this child came to you at 2 weeks of age, I imagine he is a comfortable tachypnic. Otherwise, he would not have got out of the hospital at all, or he would have come running if it was an acquired pneumonia. So this is a comfortable tachypnea. Now, what is comfortable tachypnea? So, do you have any congenital malformation? Could it be a choanal atresia? There is an obstruction to nasal breathing.
So how does choanal atresia present clinically?
Bilateral choanal atresia.
Bilateral, unilateral is
I
asymptomatic.
wanted them to say unilateral will never present or may not present. Yeah, bilateral. Excessive crying. Okay.
Because that's the only one that might appear at birth as a respiratory problem. Rest of them, severe diaphragmatic hernia, whatever, will gradually come up more and more as the time goes. So you need to be very careful whether, but there is a mouth there, no? You can breathe through the mouth, no? Where is the problem? When our nose is totally blocked, we are not distressed. We can open
So what
the
is
mouth
the
and
difference in newborns?
breathe. So why does,
we obligate nasal breathing.
very good. So obligate breather. And that is something that you must rule out straight away if at all you have a respiratory cause right at birth. Thereafter, comfortable. Comfortable is always cardiac and or congenital malformation. Both could be progressive slowly. Okay, like congenital emphysema, lobar emphysema might present over days. A cardiac also may present over days, depending on what is the pathology there. So if this child has a comfortable tachypnea, did not start at birth, you have only two probabilities. You are on a cardiac condition or a congenital malformation. Okay. Then further, how do you go about that? If it's a congenital malformation, what congenital malformation? Diaphragmatic hernia. Okay. Can you look at the abdomen and decide whether he has a significant diaphragmatic hernia?
Sorry?
Like they could have a scaphoid abdomen.
Excellent. Scaphoid abdomen.
So look at that also.
Abdomen is covered. Can you still think of a diaphragmatic hernia? Heart is on the right side and the child is tachypneic. Could be congenital heart with dextrocardia, but you will think of dextrocardia. It is not a dextrocardia, it is a pushed heart due to diaphragmatic hernia on the left side.
Because the diaphragmatic hernia, which is right severe, okay, could present fairly early at birth because there is almost a pulmonary hypoplasia at least one side. So the presentation is early, but again comfortable, slowly worsening. So that is one. Now, could it be at any tracheoesophageal fistula? He has come to with aspiration. Okay. So in that case, the symptom of something like vomiting or retching, or so there is something else there for a tracheo. Can you consider looking at the abdomen whether it's likely to be a tracheoesophageal fistula? Suppose you can see the whole stomach bloated up. Could it be a TOF? Yes, it all depends on what is the
type of
angle of that. But so keep all that in mind. But barring that, therefore, if this is a comfortable tachypnea, you are almost commonly dealing with a cardiac condition. That is fine. Now, without further history, we are at 2 weeks. Could it be cyanotic heart or a cyanotic heart? We have said it's mostly cardiac. Now, let's discuss only with that first symptom. Could it be cyanotic or acyanotic or either, or could be a valvular stenosis, aortic stenosis, pulmonary stenosis? Could it be coact?
Or cardiomyopathy.
What's your guesswork? Yes. So give a thought to that. What I'm trying to say is that if you think you can go much deeper into getting an idea what you are anticipating.
So a severe stenotic lesion would come probably in the first week of life itself, or a coarctation of aorta would come in the first week, and then after that probably the cyanotic ones could come, like the T series.
Yeah, so what you're saying is severe obstructive lesions of the left side will come with forward failure. So they'll come with shock.
Yes.
Right? Okay. Then?
And after that, like the first 2 weeks, we can think about the cyanotic heart.
So amongst the cyanotic heart, so could it be a Fallows which comes at 2 weeks with tachypnea? Why? You're right, but give a reason. So what is your concept of cyanotic heart? How would you divide them into groups for clinical understanding? Then that will give you the answer.
You are the best to tell all these things.
With increased pulmonary blood flow and with decreased pulmonary blood flow.
Correct. So if you are looking at fast breathing, it is increased pulmonary blood flow or decrease? Which group?
More like
Increased. So decreased group is out. So which is the decreased group? Fallows. So that is out. So what are you left with now? Increased may further you have two groups. What are those two groups? One is parallel circulation.
and mix means
Okay, example TGA. Why is this not TGA? Only on history?
earlier means presentation would be
What will be the normal presentation of TGA?
cyanosis.
Deep cyanosis right from the
Way of
beginning
life.
because it's parallel circulation. right? So that group is out. So the other group is admixture. So both left and right ventricular, right-sided flow is getting mixed somewhere. They have two things. One is they have failure, and second they have mild cyanosis. So if at all, it could be that group at this stage, because mild cyanosis may have been missed by the mother, right? So this is answer to sir's question.
We said TGA is out. Could it be corrected TGA? Okay. The standard TGA, yes, it will present what? What about corrected TGA? Will corrected TGA present or not present? Yeah, it's maintaining oxygenation. It's maintaining all circulation. Only the auricle, ventricle and the connections are not the usual one, but the corrected one. That means the pulmonary veins going on to the right side, but that right side is connected to the left ventricle, so again going oxygenated blood going into that. So corrected TGA does not present, right?
Corrected answer sheet, they don't fail, they pass.
And they are not tachypneic.
So that was the answer to cyanotic. Then some valvular stenotic lesions we discussed. What else can it be? Can it be a shunt?
A shunt-dependent lesion can also come fast. Like a large VSD or a PDA we would expect that to come after 6 to 8 weeks of life, like after the pulmonary vascular resistance falls. But if it's a shunt-dependent lesion, it can come before that also.
Shunt-dependent or duct-dependent?
Duct-dependent. Sorry.
So what do we mean by duct-dependent lesion? What is this concept of duct-dependent lesion?
Like for example, a patent ductus arteriosus, it basically covers up for
Correct. But let's sort this out. No, who depends on whom? Let's sort this out for understanding. So duct-dependent lesion means what? So let's start with simple. Whose pressure is higher, right or left? Left. So duct-dependent lesion means original problem does not allow blood to reach the right, the lungs, to get oxygenated. So from the PDA, you have flow from the aorta to the pulmonary circuit, and that is your only source of oxygenated blood. That's your duct-dependent lesion as a principle, right? So this is the discussion that those people will be usually cyanotic. I think so, yeah? So now what you are talking of is shunts. So come back to your shunts, left to right shunts.
Your ventricular septal defect.
So when would they present?
Mostly after 6 to 8 weeks of life.
Why?
Because that's when the pulmonary vascular resistance that falls. So that's when they can go from the left to the right side.
So initially pulmonary vascular resistance is high. It starts dropping normally. That is when the shunt is established, and that is when it starts manifesting. Now what is the change that happens if there is a large shunt?
So if there's a large shunt, then there will be equalization of the pressures.
So when there is a large shunt, the body actually tries to compensate and delay. So the fall of pulmonary vascular resistance is a little bit delayed in an attempt to delay the physiology, the altered physiology of the shunt. So normal falling, I don't think is 6 to 8. It is, it's earlier, 2 to 4. And in a big shunt, it gets a little pushed, trying to delay the shunt from manifesting, right? So 2 weeks is really early, but it could be a very large shunt which is presenting, right? Okay.
So that's exactly what Dr. Rajesh is saying, that when there is excessive blood flow going into the pulmonary vasculature, there can be a pulmonary vasoconstriction and giving rest to back pressure. Only certain conditions like trisomy 21, you can have early changes, and so the shunts could reverse faster.
I just wanted Dr. Rajesh to just enumerate 1, 2, 3, 1, 2, 3, like what he said just now.
No, so on the cyanotic discussion that we were having, so reduced pulmonary blood flow, TOF is your prototype, so Fallot's physiology. Increased pulmonary blood flow, two categories, parallel circulation, which was TGA, and mixing of blood. Examples are single ventricle, truncus, okay. So where actually there's one chamber in which both the circulations come and pour blood. So it's a mixed blood that is going out. So that's why there is mild cyanosis. But at the same time, there's too much pulmonary circulation. So they are going to be tachypneic, right? Okay. So now come back to this chat. Yeah.
Then there is that infradiaphragmatics.
That is TAPVC.
So duct dependent.
Could it be a myocardial disease? We are thinking about only the congenital malformation. What about myocardial disorders? Okay. Forget the viral myocarditis, etc. That's a throwaway diagnosis. Okay. Which myocardial problem presents very early in infancy, which you should not miss? Al-Kappa. Okay. So keep that in mind. 2 weeks may be a bit early, but I suppose it could present any time in the first few months. So keep in mind the myocardial problem as well. Endocardial is endocardial cushion defect. So we have a left to right shunts. Okay. And typically in a situation where you anticipated downs coming up, okay, mother stage, father stage, etc., then you might even consider one of those left to right shunts other than ASD, VSD, PDA. But that's different. Otherwise, there is no other endocardial problem. There is no pericardial problem at that age. And the only myocardial problem is an Al-Kappa. Right?
So just completing that earlier duct dependent thing. So what I mentioned, that the only way to get oxygenated blood was blood from aorta coming to the pulmonary circuit. Example is pulmonary atresia. So pulmonary valve is atretic. There is no pulmonary valve only. So the right ventricular flow cannot go into the pulmonary circuit. So this baby is going to die in a few minutes unless there is some blood which can reach the pulmonary circulation, which is depending on that duct. And that is why you give a prostaglandin infusion to delay the closure of that duct, right? Rarely ulta. So if your left side is totally obstructed and there is no systemic circulation, then the pulmonary say that duct is feeding the systemic circulation. Again, this is hardly any blood, but this also has to be maintained till you do something more. So total obstruction to left ventricular outflow. That's the ulta situation, right? So these are your duct dependent lesions.
Why does a congenital heart defect does not present at birth? It's in the fetus already, isn't it? So why should it not? Could it be presenting in a fetal life? If that is so, then that could present right at birth to you and me. Okay. So mostly the congenital heart never presents at birth, but the Epstein's anomaly can do that. Because the whole circulation is right-sided in the fetus, and in Epstein's anomaly, the right ventricle is arterialized, into the auricularized. Therefore, the right ventricle is very small, and that might present even at birth. So, exceptions are there that cardiac may present at birth, right?
Does anybody want to quickly revise fetal circulation when the baby is inside the mother's womb? Blood is coming from placenta. Then where is it going?
Try. We are all learning.
We have forgotten, that's why we are asking you, not because we know. Or you can trace it, no? From placenta, where will it go? To the umbilical
umbilical vein, then to umbilical vein, then to hepatic sinus ligament, sinus venous, no. Hepatic
Ligamentous
circulation.
venosus. Then
Then to IVC,
to IV. And then
to the right atrium.
RA. Okay. Then
Through the PFO to the left atrium.
to the left side. So RA to left ventricle. I'm learning. Why don't you talk loudly?
RA to left atrium, 2/3 of the blood goes to left atrium via foramen ovale, and 1/3 will go to right ventricle.
Yeah.
And then from the right ventricle, the blood goes via pulmonary artery to the pulmonary circulation. 1/3 of the blood will go to the pulmonary circulation, and from the left atrium, the next blood goes to the 2/3 of the blood which had come to the left atrium will go to the systemic circulation from there.
So where does it come to RV? How does it come to RV?
From the left atrium, sir. The blood which has come to the...
So RA to LA, correct? From LA it comes to RV.
No. From the RE to the...
Yeah. So RA to RV and RA to LA. So the one which goes to RV goes to the lungs. Is the lung an oxygenating organ there? No. So hardly any blood role is there. And from LA to LV, and the LV goes to the circulation. Then what is the role of ductus?
The right... The blood which was...
Whatever blood was going to the lungs, because the lungs is not oxygenating, so that is rerouted via PDA to the circulation, to the fetal circulation.
Then where are the lungs receiving blood from? Because lung is hardly oxygenated, but lung must also have their blood supply, no? So who is supplying lungs?
The blood, the right ventricular blood, RV blood is supplying
RV blood
the
is
lung.
going to the lung through pulmonary arteries, and that is largely responsible for circulation to the lungs rather than for oxygenation. Okay, I suggest that you go and revise again, and if we are going missing some link, and then please correct us next time.
Dr. Palniraman is there on online, one of our faculty. So he suggested congenital lobar emphysema, which may come as tachypnea in the newborn period. Bronchiolitis he has written, but not at 2 weeks. I think he must have heard 2 months. And then he said some electrical disturbances can lead to supraventricular tachycardia and failure. So rhythm disturbances and failure can also come as tachypnea, right? Okay. Now come back to our baby. So now you tell us, Devina, what is your further thought process in this baby? Now that you've said that there is increased breathing since 2 weeks to now 2 months and suck-rest-suck cycle. So first tell us what is suck-rest-suck cycle, and then tell us how do you correlate the two.
So suck-rest-suck cycle is when the baby starts feeding on the mother's breast, but then leaves sucking or leaves feeding before the before the child fulfills his or her appetite because of exertional difficulty or exertional issues. And then it's not as if then the child goes to sleep after that or goes to rest after that and then wakes up crying because the child is hungry again. So that is basically suck-rest-suck cycle.
So
The
let's
child has not
one
complete
sec.
feeding.
So yeah, so let's clarify here, because you need to pick up what is suck-rest-suck cycle. Because so what I'm asking is, do normal babies feed non-stop from minute 1 to minute 15 without leaving the breast? So they also stop in between. So then that is also suck-rest-suck, no?
But they mostly feed, like normal babies who don't have cardiac problems, they normally feed till their stomach is full and then they go to sleep.
Correct. My question is, do they stop in between or they feed non-stop?
They do stop in between.
So how will you differentiate that stopping from the suck rest wala stopping, the rest wala stopping? You got my question? Come on, some thoughts.
They take breath in between here, and there will be prolonged feeding in case of. There will be prolonged feeding, and they take in success cycle they'll take breath in between. For the they stop feeding to take breath actually.
That happens in a normal baby also. They will feed fast, then they will take a breath because feeding is exercise. Then she'll start feeding again. Newborn feeding can go on for 30 minutes also. It also depends upon how ample is the breast milk supply. If the supply is not so very forceful and ample, then baby will take a longer time. So every baby is going to stop during feed, wait for some time and restart. Then what is the difference?
The rest period can be associated with forehead sweating and like
But
they can be.
it was month of October, everybody was sweating. Suck, stop and breathless. Okay, normal baby will stop, will not be breathless. This baby stops out of breathlessness. So the mother noticed she suck, and when she stops because she is breathless. So she has a fast breathing, and then as the breathing settles down, so mother, if you ask, she may not volunteer this statement. But when you ask suck correct cycle, it's on direct questioning. So when you ask direct questioning, then you ask क्या होता है पीने के बाद, then she should come out with the answer that पीने के बाद बेबी को फसली चलती है, सांस लगती है, फास्ट ब्रीदिंग होता है, रुकती है जैसे कि उसको दम लगा है, and then she starts again and again stops. That is suck. That means suck, tiredness, breathlessness, stop and restart. So the one word which is missing in between is breathlessness. So suck, breathlessness and again suck.
Why do the normal newborns have to stop feeding? They are normal, no? Why don't they finish a feed for 20 minutes? Why have they to stop? Okay. You don't stop while eating, right?
While sucking, they
So
will not
why
be
do they
taking
stop? They stop is right.
While sucking, they will not be taking any breath. That's why they stop for the breath and they restart. In success cycle, they will be exaggerated. Since the child is breathless also, it will take more breath and then.
So do you think they get tired therefore they stop?
No, for the normal breath, they stop.
I came up the stairs and sat here. I walked and sat because I was tired or because I had to be here only. Then why it is? So during the breastfeeding, early after birth, the warmth of the mother makes the baby happy and go to even transient sleep. And the babies sometimes have to be tickled a little to say, don't sleep, come on, feed, finish. Some babies need that kind of a thing. A normal mother tells you that baby sucks for 2-3 minutes and then goes to sleep. And I put down and the baby wakes up again and feeds again. That is bonding, happiness, warmth, and the baby goes to sleep. Moment a little stomach is full and they need to be tickled a little and then they say, oh, I'm feeding, I forgot. They keep on feeding. So they are not tired, but they feel happy to be asleep, right?
And 80% of breastfeeding occurs in first 2 to 5 minutes of breastfeeding. So they are very hungry, vigorously they go on for, then 60-70% stomach is full, then there is no emergency for the baby. Then baby may even give up feeding, look at the mother, smile, not the newborn baby older, then again feed and again do some masti and feed because now the baby is no longer as hungry as it started with. So remember, it doesn't take very long for the baby to have initial 70-80% of the milk if the flow is good.
So now you connect what does the suck cycle mean? It is a equivalent of dyspnea on exertion, exertional dyspnea, which indicates what? So what does exertional dyspnea indicate? Physiology wise, what does it indicate? So cardiac failure. So now you correlate this and tell us what will it lead to? What are your thoughts now? So we discussed whether it can be what type of a cardiac disease. So now correlate and try to come to a group, and then in that group what? In this baby.
So it could be
Close.
as in acyanotic, cyanotic.
You decide and tell me both.
So it seems like an acyanotic congenital heart disease with a left to right shunt basically because it's taking away from the cardiac output.
So if it's taking away from the cardiac output, then why is the heart going in failure? I don't know if you should use the word taking away because you dug your own grave.
Simple question. Left to right shunt will reduce the amount of blood going through the left side or increase
It will
the blood?
increase the flow in the left side.
So taking away is not the right word. Yeah, go on. So left to right shunt. At what level? Atrial, ventricular, ductal. Why?
Since it has presented.
An atrial shunt would not have that much pressure difference to cause the symptoms so early on.
So the pressure difference between the atria is not much. So the shunt volume is not much. Okay. Secondly,
It could
why does ASD not present? Second reason is which side pressure is more? Left, right. So shunt is left atrium to right atrium. Right atrium to
right ventricle.
right ventricle, which is the dominant ventricle in a newborn.
Right ventricle.
So that right ventricle doesn't mind if there is extra blood. It doesn't, uska kuch hota nahi hai. So that is why ASD doesn't present, right? Okay. What about PDA?
Actually, at this stage, it is most likely to be PDA since the pressure difference will be high in the arterials area, and PDA is known to present at this stage actually.
Okay, so you are saying PDA is definitely possible. So clinically you are between a VSD and a PDA. You are saying PDA is more likely. Okay? Okay.
So generally when we talk about PDA, we think about other conditions, like whether it's a preterm child, whether it's any other prolonged NICU stay, etc. And then we think about PDA presenting. Because however large the PDA, the QPQS ratio is not going to get altered significantly to cause a failure situation. So that's why we generally tend to put VSD above the PDA when we talk at this age.
Fine. There's nothing else in the history to discuss. Large or small? Ventricular
Moderate.
shunt in this child, large or small?
Moderate is also an option. Huh?
Large, if it is, since it has caused failure, it could be large.
So it has to be large, right? Yeah. There was a history of mother having fever for 5 days in second trimester. Any relevance? Any of you want to give any thoughts? What could that 5-day fever be in the mother? Come on, start with simple things and then take it further.
That fever was not associated with any rash. It could be just AFI actually.
So you are saying because it was not associated with any rash, it was a acute febrile illness ordinary, which is possible. But does an absence of a rash rule out all other infections? No, right? So it could have been anything. We don't have any other symptom except fever to go by, right? Okay.
Just Just on the side note, if mother got fever, say maybe 2 weeks before, and then the child was born, anything else that comes to your mind, and then there is some cardiac issue in the child? I'll give you a hint. Any medication to the mother that could cause some problem to the baby? An SCI-induced closure or early closure of PDA or premature closure of PDA.
Mother is on thyroxine. Will it give rise to hyperthyroidism as the baby? Transient? Why not?
I'm not sure if thyroxine crosses the placenta. It
Okay.
doesn't.
And maybe when you give thyroxine, the mother is already deficient in thyroid. So by giving thyroid, you are normalizing the thyroxine level. There is no excess thyroxine, so it won't.
There's a history of neurofibromatosis. So how is it relevant to this discussion or not?
So there is just a finding of, like the child just has cafe au lait spots on his body back.
Okay.
Huh?
3 generations family
There are
history.
3 generations of family.
Mother also has. Mother also.
Autosomal dominant.
Where will you think cafe au lait is significant?
More
The
than-
baby is asymptomatic. 5-year-old child I have, asymptomatic. But I see quite a few cafe au lait. When I will think that it is significant?
More than 6 in number with the...
Pardon me?
More than 6 in number with at least 0.5 centimeters.
Yeah,
of it.
0.5 or 1?
Point-
0.5 centimeter, and especially look at the axillae. Especially if they are there in the axillae, then they add to the gravity of situation.
And if there's a family history. as
And of
well.
course families.
See or have history of neurocutaneous stigmata, and you have a child with heart problem. Can you think of some association?
Tuberous sclerosis has
Tuberous sclerosis with rhabdomyolysis.
So my summary after the histories, this is a 2-month-old female child with complaints of increased respiratory activity since 2 weeks of life, with complaint of succurrous suck cycle and forehead sweating, with IUGR and maternal history of fever at 5 months of gestation, and significant family history of neurofibromatosis, could most likely be a case of acyanotic congenital heart disease with left to right shunt and features of CCF with NF1 to rule out torch infection.
Why rule out torch infection?
So basically because it might not be significant, the maternal history, but the child was a full-term baby with was IUGR.
So, okay, so
Out of TORCH,
Could be cytomegalovirus or rubella. So rubella has a association with heart defects, could be that.
okay.
So coming to my examination, the child was awake, alert, euthermic, heart rate of 156 per minute, regular in rhythm, large volume, collapsing, RR of 60 per minute, SpO2 of 98%, BP was 72/54 in the right upper limb, and in all the other limbs it was 70/50 mmHg. Peripheral pulses were well felt and extremities were warm. Sugars are maintained and CRT was less than 3 seconds and pallor was present. Anthropometrically, the child
One
is
sec, go back.
Sir, the patient is...
pardon me for going
Sir.
back, there is one symptom or sign which directly points to a cardiac disease in that succurrous suck cycle business. Which is that?
Increased precordial activity.
Yeah. So was it inquired? Because if there is increased precordial activity, respiratory problem is ruled out. So remember this manifestation which directly points to a heart disease.
What is your comment on the blood pressure?
The blood pressure was basically maintained in all.
Speak in the mic.
It was between the 50 to 98th centile in all the other forums, and there was no major discrepancy in the both.
No, so I think sir is also asking what is the pulse pressure like, and then I am asking you a further question. So what is the pulse pressure here? It's normal?
No.
How much is the pulse pressure?
Basically,
20.
18 or 20 in that other one? Yeah. So is it normal?
It's not a wide. Not a very wide. It's
Yeah,
not
so
more
is
than
it
40.
too narrow? First answer whether it's normal or it's too narrow or what. And then when you say not a wide means, what are you trying to say?
It is not a high, based on the BP, we can say it is not a high cardiac output state.
High cardiac output state, okay. Also, what is the relation of a collapsing pulse to the BP?
Pulse pressure will be wide in collapsing pulse.
Very good. And so I give you two wide pulse pressures. One is, let's say 120 by 70, 50 ka pulse pressure, right? And I give you another one where 100 by 30. Which one will have a collapsing pulse? So collapsing pulse also needs to have a low diastolic, abnormally low diastolic. Why do you call it collapsing? Because there is a runoff of blood. So diastolic pressure is very low. Classic example is your aortic regurgitation, right? So according to me, these two words don't go together. Collapsing pulse and this BP doesn't go together.
Actually, normally the pulse pressure, if it is more than 50% of the systolic, then that's normal, that's increased. And if it is less than 25%, then it is small. This is just borderline 25%, 18 and 72. So it's 25%, it's just within normal limits, but not one of a PDA type. That's what I wanted to bring it out. So always look at the pulse pressure also, above 50% of systolic or below 25% of systolic is abnormal, around 1/3 is normal.
Where else would you get a narrow pulse pressure in general? That's the next question. So in general, you see any child and you have a narrow pulse pressure. What is your thought process? कि चल जाने दे ऐसे ही mistake है. कि you are worried as Tushar said. Why? Why impending shock?
The systolic volume will be less and diastolic there will be compensatory tone of the blood vessels will be high. That's why there will be narrow pulse pressure.
Yeah. So one of the first stages of compensation for shock is narrowing of pulse pressure. Right? Yeah. Okay, go on.
Blood sugar was maintained at 117.
He's not feeding well, right?
not,
So he's starving.
Yeah.
And he has 117.
So, anthropometry, the weight is 2.55 kg less than -3 standard deviations. Length is 52 centimeters, which is between -3 to -2. Weight for length is less than -3, and the interpretation is the child is failure to thrive. Head to toe examination.
One sec. Let's someone come and examine the baby. Benji, लेके आएंगे बच्चे को?
Normal range of length at newborn. What is the normal range of length at newborn, and how much does the length increase in the first 3 months of life? What's the average length of a newborn baby?
50 centimeters.
50. And how much does it increase by in the first 3 months? Pardon me? 4 centimeters per month for first 3 months. Then it progressively down. So the baby who is 50 becomes about 60 at 3 months, but only 66 at 6 months, and 70 or 71, 72 at 9 months, and 74, 75. So see that progressive fall in the rise of him. So as much as 4 centimeters in first 3 months of life. And how much does the head circumference increase in the first 3 months of life? 2 centimeters, and then progressively.
Some volunteer to come and first just inspection, observation. Come. Come, anyone. Come. We'll just observe from a distance. Come, very good. You can just ask her to little open up, not too much disturb, and just talk about what you feel. बन क्या है हाँ? थोड़ा ये भी ऐसा थोड़ा निकाल दो, ओके?
You can pull a chair and sit next to the baby.
So the child looks to have retractions, labored breathing.
Obviously tachypneic, correct?
Yes, sir.
Tachypneic with distress, tachypneic without distress.
There are retractions, so mild distress.
Comment on the retractions.
The retractions are subcostal.
When you start observation, first talk about whether he is acutely sick, chronically sick, or not sick at all. That's number one. Talk about growth, nutrition, if possible development, what you can observe, and then get on to the system, right? And then, of course, we don't want to disturb the baby, but otherwise see the baby naked and see whether there are any malformations obvious, but yes. So, what is your comment on 2-month-old baby's growth, nourishment?
The child looks not appropriately grown.
Likely it's not appropriate. We don't know the birth weight, but still doesn't look like. Acutely sick, chronically sick, or comfortable?
The child looks sick, but he's comfortable, so I'm assuming he's chronically sick.
The baby seems to be sleeping. Okay. So the tachypnea seems to be not disturbing or coming in the way of sleep. So reasonably comfortable, but pretty fast respirated. Go ahead.
The respiratory rate is around 76 to 80 per minute.
What is upper limit of normal at this age?
For 2 months of age, around 60 should be
50
okay.
to 60,
The moment
yeah.
you see tachypnea, the next is there a respiratory distress or no distress? What do you think? Is there a respiratory distress?
No, sir.
If so, why?
What about elinasa?
No, there is no nasal flaring.
So at this age, why is that question so important, that is there respiratory distress or
we want to go
no?
close and see whether there is nasal flaring. There is nasal flaring.
There is nasal flaring.
Yeah, why is that question so important at this age in a tachypneic child, whether there is distress or no distress? Because if there is no distress, you are thinking of acidosis, and if there is distress, then you are thinking of your cardiorespiratory causes, right? Because it's an infant, so you are also thinking of acidosis as a differential, no, for that.
What about abdomen?
There are no obvious hernias, no distended veins. That-
Umbilicus is little down, which means there is something occupying in the upper abdomen, which means the liver is large. So you have a respiratory distress, not very uncomfortable child, so cardiac, large liver. So you get all this already on inspection, right?
And just for technically being correct, when you have not pulled the pants down completely, don't say no hernias, because you still have to see the inguinal region and all that, right?
And you see very clearly when the baby is breathing, the upper chest is moving up, the abdomen is moving down, and in between there is a retraction. There is a lower chest retraction during, so this kind of breathing distress occurs in what kind of? Cardiac problems, and especially if there is a pulmonary problem, there may be intercostal breathing. Okay, here the lung look to be relatively full, and therefore there is no impairment of excursion. Okay, only the lower part is very clearly, two things going up and middle things going down.
And I think whenever there is a congenital heart defect, just look at whether there is any obvious other abnormal physiognomy. Many VSDs, for example, have many other syndromic abnormalities. Okay, so also comment on whether the head size is normal, whether the facial characteristics of any syndromic nature, or whether there is anything else, right? Good. Now somebody just palpate the abdomen, see.
We wanted them to comment on growth.
So the child looks not appropriately nourished, considering the child had normal birth weight.
No, it was 1.7, but even for that 1.7 2-month baby, assuming that breastfeeding is adequate, make sure that the breastfeeding is adequate. आपको दूध काफी है? Then the baby is not getting enough.
Just palpate. Okay, and just one auscultation. Will not disturb the baby much. Can you do that now?
Yes, sir.
And then give your findings.
Palpating, what are your aims of
Status.
You are not going to
Yeah.
palpate blindly. First tell me what are your aims.
What are you looking for, sir, is asking.
I'll look for enlarged liver first, because that is one visible inspection. That was one of our doubts.
Enlarged liver can be displaced liver or enlarged liver. So how will you know whether it's a displaced liver in a tachypnic baby or it's really an enlarged liver?
Sir,
You all, come on, you all answer.
we can percuss and know the total liver span, and then
Very
So
good.
what is the normal liver span at this age? 5, 6, 7, 8,
5,
9, 10?
5-6
5.
centimeters.
4.5 to 5.
Right. So what are the aims of palpation? One you said is whether there is a hepatomegaly.
You examine somebody else.
Second,
One of you answer.
No, you start examining, somebody will
the
answer
baby
Khare
starts
sir's
crying.
question.
I want to know one. There is
Like
cardiomegaly or no? If there is cardiomegaly, then which side is contributing to the cardiomegaly? Atriums will not. So RV, LV or both? Okay, number one. Number two, if there is enlargement of one of the ventricles or both ventricles, why have they enlarged? Because they are doing increased work. So is the increased work because of systolic overload or a diastolic overload? So cardiomegaly, if cardiomegaly, which ventricle is dominantly enlarged, and if it is, then whether this is a diastolic overload or a systolic overload. Systolic overload means there is obstruction to the next level of going. Diastolic overload is volume overload. That means something else is coming in the ventricle more than what it should have, which will normally mean a shunt. So systolic overload means obstruction. So for example, LV systolic overload could be aortic stenosis, coact, etc. While LV diastolic overload means something else is coming back into the left ventricle. Left ventricle has to come more than what it is. So it's likely to be VSD or one of the C styles. And how do you clinically recognize between a systolic overload and a diastolic overload? One normal. In normal there is is tapping apex speed. Comes, taps and goes. Tapping apex speed is normal. Systolic overload is, there is increased systole. That means your finger may be raised. It's little difficult to appreciate. And diastolic overload is, there is increased work. The finger is raised, but it is not raised significantly for a longer time. So this gives you the basic plan of how the heart is. Cardiomegaly, right side more dominant, left dominant, diastolic overload. So you have narrowed down the diagnosis so much. And then you want to know about the pulmonary circulation, systemic circulation and venous circulation. So systemic circulation idea from pulse and blood pressure. Pulmonary circulation idea from, to a certain extent, from the second sound and a split in the sound, widely split, not split, and how big is the second sound. And the right side is from the venous side, the hepatomegaly. So if you know this, then you know the hemodynamics. Nothing more is required. Auscultation is perhaps the last that you will require. You will have the diagnosis before you put the stethoscope on the chest. So let's try and attempt that.
So tell us your findings, whatever you got.
Sir, on palpation, the liver was enlarged around 2 to 3 centimeters below the subcostal margin, and the spleen was also there.
Span?
Sir, total liver span, I did not measure.
Okay, you couldn't check. Okay, go on.
And on auscultation, the breathing sounds, the lungs were clear, air entry on the both the sides was equal. And in CVS, S1, S2 was present, and there was murmur, and I think it was pansystolic murmur.
Okay. Now you tell us your findings and then we'll interpret everything.
Did you hear any other murmur than pansystolic murmur?
Would you like to comment on the quality of murmur?
Machinery murmur, but...
Is it machinery? Is it a rough murmur or a soft murmur?
It's a rough murmur.
Rough murmur.
Rough, harsh.
Okay. Quite a rough murmur. What is it written in book? Rumbling. Every word is important. Rumbling, pansystolic murmur, not radiated to other areas. So that's a complete description. Quality of murmur also matters.
On head to toe examination, frontal bossing was present, AF was open, no dysmorphic facies, eyes, oral cavity, spine, limbs were all normal. Skin, multiple caphiolar lesions measuring 6 to 7 mm in diameter, present over trunk and lower limbs. On systemic examination, CVS inspection, trachea was in the midline, trachea is in the midline. Apex beat was located in the 5th intercostal space in the mid-clavicular line. No precordial bulge, parasternal and epigastric pulsations are present. No scars, sinuses and dilated veins. No kyphoscoliosis. Chest wall is symmetrical. Palpation, tracheal position has been confirmed. Apical impulse at 5th intercostal space. Mid-clavicular line, hyperdynamic type. Palpable left parasternal heave of grade 2. Systolic thrill present in lower left sternal border. Epigastric pulsations are felt and carotids were normal and no thrill was present. On auscultation, high-pitched harsh pansystolic murmur of grade 4 was present over the left lower sternal border in the tricuspid area, left lower sternal border, and nothing else in the other areas. Per abdominal examination was soft, slightly distended. Liver, 4 to 4 centimeters, smooth, sharp borders, moves with respiration with a span of around 4.5 centimeters. Spleen of 4 centimeters, firm in consistency, smooth, moves with respiration. Respiratory examination, air entry is bilaterally equal. Conducted breath sounds are present. Bilateral, subcostal and intercostal retractions are present. And the cry tone and activity of the child is good. Impression.
So 1 minute, before you come to impression, can you interpret all your positive findings of CVS?
Construct the diagnosis.
So, coming to the inspection, the palpation, So the apical impulse could be felt at the fifth intercostal space and was hyperdynamic in type. So there is some sort of, along with the left parasternal heave, we can think of a right ventricular.
Is there a cardiomegaly? Maybe not significant.
Maybe not,
Fifth
yeah.
is there. Which ventricle is dominant?
The right ventricle.
But why is there parasternal heave on the left side?
That's one comes now. No, left now.
So
No.
there,
So that hyperdynamic type of apical impulse means what? First, which kind of a
The
impulse?
volume.
No, what kind of a feeling will you call as hyperdynamic? How does a hyperdynamic impulse feel differently from a normal apical impulse?
what is normal apical impulse called as?
Just touch and go,
Yeah.
Just touch and go.
It's called as tapping.
tapping.
But hyperdynamic.
In hyperdynamic it will be more but not sustained, not
Very
for
good.
more period.
So to describe it, you can say forceful but ill-sustained. Okay? So that's your hyperdynamic. That suggests volume overload. Okay?
Of the left ventricle.
Left ventricle. Yes. And then what is parasternal heave suggest?
It suggests right ventricle is also involved.
Very good. So parasternal heave is a sign of right ventricular hypertrophy. Okay?
And add to that, which suppose right ventricular, is there anything to add to that? Epigastric
Epigastric
pulsations are also felt. So that also adds to the RV. Am I right?
Epigastric pulse.
Yes, sir.
So
Then-
LV and RV.
Then systolic thrill means what? You all answer. What does that thrill mean? Interpretation of that
That
thrill.
is a palpable murmur.
Okay.
Anything more than that? The murmur was because of pulmonary circulation. There was some obstruction to the pulmonary artery narrowing, and that's why the murmur was there. How does thrill give you additional information?
Very good.
So where the thrill is felt the best, the heart problem, the murmur is arising directly underneath the structure which is there.
Right? So that is the anatomy of your problem. Okay? So now, so far, what have you got? You got both ventricles. Okay? And you've got a anatomical lesion which is near the lower left sternal border. So what kind of a lesion is situated there usually? Ventricular septal defect.
And
Right?
the second sound in palpation?
She's not mentioned it, but you should mention whether second sound is palpable or not.
And there is one very simple and important palpation which we almost never carry out, which distinguishes VSD from ductus. Put your finger in the suprasternal notch without being too aggressive. And if you get a pulsation there, almost certainly it is ductus, because other things will not give rise to pulsations.
Go on.
Would you expect a right ventricle in a VSD? You have everything like a VSD so far, but do you expect a right ventricle in VSD?
If there is a pulmonary arterial hypertension, then
Pulmonary hypertension. Yeah.
On auscultation, there's a high-pitched, harsh, pansystolic murmur of grade 4 over left lower sternal border, which could point towards VSD.
So which corresponds to that VSD murmur, right? Now a better way to describe your heart sounds, see when you say heard in all areas, then examiner wants to finger you. So he'll say in which situation you don't hear the heart sound in that area, and you don't have an answer. So you should describe it as the first heart sound as auscultated in the mitral area is normal or whatever. The second heart sound as auscultated in the pulmonary area is normal or second pulmonary component is loud or split is wide, whatever abnormality you want to decide. You don't have to talk of all areas and repeat the sounds, okay? So it is convention that first heart sound is always assessed in the mitral area and second heart sound is always assessed in the pulmonary area. This is the convention.
Out of the two sound that you hear, second sound, which is the first one and which is the second one? Yeah, but which component? Aortic and pulmonary. The first is aortic or the second is aortic?
Usually first is aortic. If pulmonary hypertension is present, then pulmonary comes first.
I think 2-3 things. If the murmur is harsh, likely the defect is small. Okay, here we are expecting a large defect. That's number one. Just take a note of it. Yeah. See, for most of us, harsh or not so harsh is not easy. But when you tell an examiner, then don't say harsh, because that's a harsh question will come. Okay, that's number one. If P2 is normal, then there is no pulmonary hypertension. Then my worry is there a ASD also? And let's call it a complicated VSD, because you don't expect a right ventricle to come up here. And then always mention a diastolic murmur, present or not present, because as pulmonary hypertension start developing, you start getting a diastolic murmur, and when it gets even severe, the diastolic murmur disappears, and in fact the murmur itself also may disappear. Okay, so take a note of that. See, with such a small child, our findings are not so easy. But when you have decided to put it as VSD, tell the examiner VSD findings, so that he might say you have missed something, but I can justify what I have said, right?
What was sir talking about diastolic murmur? Where diastolic murmur in VSD? What is MDM?
Due to the excess flow, there can be a functional mitral stenosis that would give like
excessive blood flow across what valve?
Mitral valve.
Yeah, why?
Because of the left to right shunt, the final
Yeah, so
load is
that
more
much
on
of
the
blood
left
is going again to RV and is again entering. That may be one of, usually in VSD we may get biventricular also, right more less than left, because left ventricle has to pump more because some blood escapes into. But a right ventricle also with every contraction is getting more blood, one coming from vena cava and one coming from LV. So there may be biventricular, but more prominent is LV than RV. When RV starts coming up, you think of pulmonary hypertension. If I were to very grossly generalize, LV, PDA, biventricular, VSD, right ventricular, ASD, with limitations.
So do you think so far you have also possibility of a primum ASD? You have a left ventricle, you have a right ventricle. Okay, because we are not able to fit harsh murmur, pansystolic murmur, normal P2, no diastolic murmur. So the point is, it's such a small child, I can imagine findings cannot be, we are not good at. Even the cardiologists today will not be. They will go by. So we are not worried. But the point is, examiner might ask you all these discrepancies. So you might anticipate those discrepancies and not even mention those, even if you thought. Right?
Do you want to auscultate the lungs? She said so. Yeah, no. Any time you want to auscultate the lungs, in which cardiac disease, you are keen to auscultate very closely in the axillae, in lungs.
So like radiating, the murmur would be radiating to the axilla.
I have a pulmonary atresia or decreased blood flow going to the lung, then what happens? Are there any collaterals taking place? I heard of bronchial collaterals taking place, and bronchial collaterals are best heard in axillae. There may be a continuous murmur, and bronchial collaterals tell you definitely that there is pulmonary oligemia. Otherwise, bronchial collateral. So there is a place for auscultation of a lungs also in a child with heart disease, especially the cyanotic heart disease.
Which other cardiac condition you want to look for collaterals clinically? At the back, very good. Where? Which one? I thought you were pointing at the back, right? Coarctation of aorta. Very good. What do you see on X-ray?
Notching of the rib.
Notching of the ribs. Good.
So my impression is 2-month-old female child born of non-consanguineous marriage with history of increased respiratory activity with complaint of suppressed suck cycle and forehead sweating since 2 weeks of age with hypodynamic apex beat grade 2 parasternal heave and pansystolic murmur with hepatosplenomegaly with pallor and cafe au lait spots with family history of neurofibromatosis with FTT with IUGR could most likely be a case of acyanotic congenital heart disease with left to right shunt, probably moderate to large VSD, with features of CCF without infective endocarditis, with NF1 to rule out torch infection.
What all features of NF1 did you see in the child? Cafe au lait spots. What else?
Family history and capacity.
Family history. Anything else? What else would you look out for?
Axillary freckles, but they will appear later in the life. Now,
Excellent. So that's what. So just like tuberous sclerosis, there are these three things usually come up much later on in age group, 4 to 5 years of age. And if you see freckles, which we don't see commonly in our ethnicity, as I would put it, if it is present on non-exposed area or non-sun exposed areas, they are even more important to be associated or connected with the NF1.
She said without evidence of infective endocarditis. So why the spleen?
Torch infections.
How big is the spleen?
Around 3 to 4 centimeters.
4 centimeters. Because otherwise normal newborns can have spleen, and you have a child who is breathing so fast will have pushed down spleen. So even those are the other options.
Okay, tell us the investigations.
Actually, I'm supposed to put the photo of the X-ray, but it's not come in this. It's not come in the PPT actually.
What things would you want to see on the echo? That's what you should. If you see the echo report, I'm not expecting any one of us to read an echo, but if you see a report, what will you be looking for?
Size of the lesion.
Very good. How do you judge the size? Apart from the value, of course, is given, but how do you know that it's small, big, or mild, small, moderate, or severe?
Gradient.
Amount of blood flow.
No, that's your pressure gradient.
Systolic
right?
gradient. Systolic gradient.
Systolic gradient? I thought it was something to do with the aortic root size. I'm not too sure. But you compare the aortic root size of that baby with the VSD size, and there are some calculations on that. What else do you see? Quickly. You said size. Then what else?
Any pulmonary arterial hypertension if present.
Go on. Now, there are few things that you see normally. What else? On echo, what else do you see?
Vegetations and...
Vegetations, okay. Accepted. Ejection fraction, okay. Ventricular size. What else? Associated abnormalities. So it could be only VSD or could be more than VSD. Then?
Any collaterals in some diseases where collaterals develop.
Okay.
You also confirm the situs as in concordance and situs, right? Yeah.
I have taken an X-ray chest. You have not seen that. Expect what do you see? Expect. You have not shown the X-ray. But I expect the following things on a X-ray chest in a child with moderate VSD.
There will be cardiomegaly.
Cardiomegaly. How do you judge cardiomegaly? Anybody?
You have your X-ray here. It's on your mobile.
Yeah.
मोबाइल पे एक्सरे दिखा सकता है कोई मेथड से?
Heart to thorax ratio
How much is it?
in newborns more than 0.6.
Yeah,
क्या करने
0.6. And where do you see the ratio?
मोबाइल दे उसको.
So
How do you see the ratio? Yes. How do you see the rotation of a X-ray?
clavicular position.
Look at the clavicles and the inner and the medial end of the clavicles and how they are separate. Plus, if there is a rotation, how do you judge a cardiomegaly? Do you see at one place you draw only one line? No. So you draw a line in the midline, and then from one perpendicular comes to the maximum size on the left side, and one perpendicular comes on the right side, and you count that, and if it is more than 0.6, then it is cardiomegaly. So there is cardiomegaly. Number two, which ventricle is contributing?
Usually right ventricular in this case, so it will.
हाँ?
Honest
Online
saying,
दिखेगा, ठीक.
it is not very easy and correct to comment on the ventricular hypertrophy in a PA X-ray. The ventricular hypertrophy is best made out on a lateral X-ray. Dead lateral or RAO, LAO? We were taught about RAO, LAO. RAO, LAOs are more for atrial hypertrophy. Used to do it in mitral stenosis. Left. So dead lateral is best. So in dead lateral, if the retrosternal place is obliterated, then it is RV. And there is a enlargement more towards the spine, then it is LV. So best view is that on PA you can comment to a certain extent whether the LV or RV is dominating. So cardiomegaly, LV, RV dominance, and the most important thing is, see, both are present. For more accurate diagnosis, you would take a lateral. And most important thing is pulmonary hyperemia or oligemia. So how do you look at pulmonary hyperemia or oligemia? Not easy, unless you are used to that.
चल, anybody wants to read this? Try. Try, whatever you know. Take the mic.
So this is a
Hold it close, mic.
X-ray chest PA view. The clavicles.
AP or PA?
This is AP.
In children, you take AP but call it PA. Okay? Why?
Because we cannot make them if we take supine position.
Yeah,
so it is
they move less. So there is a little difference what will appear prominent, etc. But that's fine.
Apparent cardiovascular.
Yeah.
Hold mic.
The heart appears to be enlarged.
Is it a well centralized film?
It is a rotated.
Rotated.
The claustrophrenic angles are clearly visible. There is a increased bronchovascular markings are seen in the lung fields. The heart appears to be enlarged with apex being rotated, so not.
So it's actually a rotated film, so I don't think we can comment on that. You can only comment on cardiac enlargement, right?
So how do you comment on vascularity? Not easy. One is you will look at the size of the pulmonary artery as it's in the right side. In a rotational X-ray is difficult. You see how prolonged is those blood. Blood vessels are seen as white. Are the bronchi seen in the X-ray? No, because they are filled of air. So they will see more as a hyperlucent area rather than an opaque. So what is opaque is blood content in blood vessel. So you follow that opacity and how long it is extending up to. But more importantly, if you are able to see any transversely cut artery or blood vessel, then you see that particular transversely cut as a circular thing which is little more dilated. So one or two vessels you will be able to, which are transversely cut. So you look at that and you look how long, how far is the white line going about that. So that comments upon pulmonary vasculature. Only after you see many cases, then you are able to comment on pulmonary vasculature. And vasculature which is there in the proximal portion and peripheral cutoff is, there is increased vasculature in the midline and there is peripheral cutoff. Pulmonary arterial disease, because of that there is peripheral cutoff, that means significant pulmonary hypertension because of the pulmonary arterial disease.
Yeah. Go on with your other findings.
So this is the CBC. Should I go to the 2D echo report only?
Anything significant in the CBC?
HB of 10 and hematocrit of 20.51 and WBC of 18.7 and platelet of 2,27,000 only significant. But the rest OT is maintain about 83/49 and come to the 2D echo. So they found this. We actually had two 2D echoes done. We had one done by our pediatric 2D echo as well. This is like adult 2D echo. So they found there to be a 5 mm OS ASD with left to right shunt and a large mal-aligned restrictive VSD with left to right shunt. 1 second. And a 3 mm PDA with left to right shunt restricted by with a mild TR, mild PEH. That's what they found. So basically OS ASD, PDA and VSD. And in our pediatric...
There was pulmonary hypertension?
No.
Mild PH,
only,
okay.
1 second. And in the pediatric 2D echo, they found there to be levocardia and a double outlet right ventricle to be there. Yes. Which is not mentioned in the other one. And there was a large VSD, left to right shunt, and a large PDA, left to right shunt, which was found. With a dilated left atrium and a left ventricle.
So saturation was 100%?
Yeah. It was around 98%, to be exact.
On room air?
On room air.
That's what we are wondering. So DORV, can it exist with this kind of a saturation?
Unlikely actually, but because it's an admixture
Yeah,
physiology by
that's what we
itself.
just discussed in the beginning, no?
So that there were two 2D echoes done. So one mentioned DORV, the other did not.
Okay.
Yeah. So actually we had sent torch titers as well for the child in view of IOGR and all the other findings. So the child actually tested was reactive for cytomegalovirus IgM antibodies. So that was one positive finding that he found to be.
Mothers?
Mother.
Yeah, they would not come as yet.
Because 2 months is a very tricky time to do a torch level. If at any time it is tricky, but at 2 months it's even more tricky because now you don't know this is acquired or congenital. Unless you see mothers and she has an IgG positive, then also you are not sure, but at least gives you some credence that this is possibly congenital. But if she is IgM, IgG both negative for mother, then this is probably acquired.
Fundoscopy normal?
Even otherwise, otherwise, an IgM positive at this time, whether it can be correlated to the first trimester congenital heart, unlikely.
So no other features for cytomegalovirus was found.
No other features, yeah.
So how do you know, at least you have a CMV IgM positive, you want to know it's actually infection is there or not there, how will you know?
CMV PCR.
CMV PCR, right? Okay. Anything else you have done for this? OAE, BERA?
BERA plants.
Plant. Okay.
Does the baby have normal development brain-wise?
So the baby has social smile.
No, this baby clinically.
That's what she's saying.
Till now,
She's describing social smile and
Yeah,
all.
oh sorry.
Developmentally, it's a bit difficult to gauge at this point of time. Rest just does not seem to be any lag as such.
No, so social smile
Social
is...
smile is
Social
present,
smile
yes, and he
is there.
visually fixes.
Is it a spontaneous smile or a social smile?
Seems like a social smile. It's not-
Why do you say that?
Because when you look at the child, then the child smiles back at you. A spontaneous smile would just be there.
Okay. How will you manage this baby?
So for all these, so we could actually go for corrective surgeries for the child, and for anti-failure management could be started.
And you have to give 5 heads. Nutrition of the... So say, exam mein you have to practice all this. Say.
So for proper breastfeeding of the child, we have to guide the mother how to breastfeed the child, because the child has history of poor weight gain, and rest.
But breast milk is adequate according to her.
But the
You
correct
can't do much on
positioning,
that
not
front, or you can still do a little bit on that front.
We can fortify the feed.
Can express the breast milk to reduce the work of suckling so that the baby gains some weight. We can, as she said, add more fortifiers like MCT oils and
Yeah.
milk fortifiers.
Then, so anti-failure line of treatment, then continue breastfeeding, see if you can augment it, then
Anti-failure में digitalis, no digitalis.
no,
We used to give digitalis to everyone.
they don't know what is digitalis.
So we'll have to counsel the mother as well regarding the condition of the child and what is supposed to be the prognosis and what can she do about it. Yes,
Definitive surgery.
definitive surgery. Yeah.
Okay. Fine. Sir. Any other questions? Any doubts anybody has?
So what is the appropriate time to send the torch titers then if we
Sure.
are...
So it's a very tricky question actually. If you have evidence of active torch infection, then only one should send torch titers. If you are actually looking for a, say, intranatal, first trimester rubella, there is no point in sending a torch titer now. You might as well check the baby for any stigmata of fetal damage or fetopathy, whatever term you want to use, each related to this condition. Early on in the newborn period, you do mother and baby both together. You have a diagnosis, you can treat the mother for subsequent infection, at least for toxo and CMV, not for anything else. We are not talking about syphilis or HIV or other conditions.
Anything else? Any other questions? Okay. So thank you, Devina, and thank you all of you. I think we had a very nice learning experience. You all will all agree. So physically, there's definitely better interaction. You all can also participate better. So please tell all your friends also, and let's continue this kind of a hybrid class where physically you all are there to examine. That is also very important. And plus we can get online people to view the class also, right? So spread the message to all your friends in other colleges as well, and try to present 2 cases. The second case can be even a very short case. We need not discuss the history in long, but we have to practice examination, interpretation of clinical findings. All this is very, very important. At the recently concluded DNB exams, again, many of us were examiners, and what we found lacking was that students couldn't construct things, as Khare sir said, couldn't defend findings, and so many of these things. So these are the things we have to learn. You all can do reading from your books, but all this learning to speak, you will learn here, right? So please tell your friends also, and please come regularly. reach at 5:55 because we are online, so we have to start sharp at 6. Okay? Thank you very much. So 1 minute.
I think the second case could be a recovering child who is getting discharged next day. We could just do clinical examination. We might do neurology. If it's an older child, we could do only abdomen. Okay, recovering child. Okay, even that is fine. So one good case to discuss and another short one for observation from only palpation, only auscultation, something of that kind. Okay, that would be a good learning way, right? Thank you very much.
Thank you. Thank you to all our online viewers and our faculty online. And we once again express our gratitude to Sion Hospital and to Aristo Pharma for facilitating this webcast.